Hello, everyone, and welcome to another episode of Autism Stories. I'm your host, Doug Bletcher, the founder of Autism Personal Coach. Autistic people are the true experts of the autistic experience, and Autism Stories is where we interview autistic people to learn from their stories, experiences, and get their insights. If you would like to be notified about each week's episode of Autism Stories, we suggest you subscribe on your favorite podcast listening platform. We would also appreciate it if you could give us a positive rating and review, as it will help others to learn about autism stories. On today's episode, Dr. Liliya Wheatcraft joins us to discuss being a psychiatrist, evidence-based medication, and defense mechanisms autistic people may employ during the grieving process. We hope you enjoy today's conversation. Dr. Wheatcraft, thanks so much for joining me here on Autism Stories.
No, thank you, Doug. This is very kind of you to invite me, and I'm really delighted to join. I really enjoyed your previous guests, listening to your previous podcasts, and I have really been looking forward to this. Thank you.
Thank you. And I'd love to start out our conversation by learning about where does your story in the autistic community begin?
Oh, gosh. It begins well before my own diagnosis. The first person that I knew was on the spectrum was actually my husband. We met back in the year 2000. We met online at the time when meeting online wasn't the thing. So actually for a very long time, only our closest friends knew that that's how we met. We had corresponded for 9 months before finally meeting in person in Austria. And it's in the Natural History Museum of Vienna that I realized that Tony is different, because a bunch of kids came in, and, kids were about 6 to 8 years old, and they were being loud and shouting, and I saw Tony's face contort in pain, and he covered his ears and ran out of the room, which was really shocking to me at the time, because I had never witnessed anything like that. So I followed him, and that's when he told me that he doesn't deal very well with loud sounds, especially when he is already stressed. I knew nothing about it. He didn't know much about it. He was the only person out of his circle of friends and in his family who had this difficulty. So when I went to Cambridge, a year later, made friends with psychologists and with people doing sort of audio research, audiologists. And even then, nobody told me that, this might be a sign that he is on the spectrum. I mean, I knew that he was on the spectrum because he himself said, I'm probably on the spectrum. So, okay, that's fine. We're all different. Looking back, I'm thinking about the faces of people, how people's faces were changing and how they were looking away, and sort of carefully explaining to me that, this is common phenomenon among some men, but really you can't do anything about it, because at the time I thought, there must be a cure for this. But no, there is no cure. So basically, all you can do is just to reduce the amount of noise that he's exposed to. And then 1 year later, our son was born. So after my first year in Cambridge, our son was born. And as he was growing up and developing, I realized that he is different. Not good, not bad, not just different. He was very clingy, in a sense that you really couldn't put him down even for a moment. He always wanted to be held when he was a baby, which then changed very suddenly and dramatically over a period of a couple of days, where he didn't want to be held and didn't want to have anything sort of tactile other than clothes, and even clothes were not particularly welcome, especially if there was anything beyond simple cotton, loose clothing. And he was very active. I remember we went to the cathedral, Ely Cathedral, which is about half an hour by train from Cambridge. And that was mortifying because I was the only mom in the whole cathedral with a child of that age. And there were about half a dozen of other children, age 7, 8 months. And my child was the only one who wouldn't sit in the chair, in his pushchair, would make ruckus if you tried to keep him in a pushchair. And the moment you took him out of the pushchair, he would start crawling all over the cathedral. So this is, I guess, where my journey in the autistic community begins, because this is when I started researching what is going on. He's very bright, and he met all his developmental milestones on time and ahead of time, but there was always the question of why is he behaving different compared to the majority of his peers. And then I did a rotation in pediatrics, doing community pediatrics, outpatient clinics with a consultant. I first came across children with neurodevelopmental conditions, which started giving me some ideas, but really I wasn't confident that he's on a spectrum until he was formally diagnosed, because I didn't believe, yes, I diagnosed him, 3 or 4 years before the formal diagnosis was made when he was 9, but I still couldn't rely on my own assessment because I know how subjective you can be as a parent or as, a family member. They have this, we have this phenomenon, the medical students phenomenon, when we diagnose ourselves with all sorts of things. I think Jerome K. Jerome wrote about that, saying something to the extent, by the end of my second week, I diagnosed myself with everything apart from pregnancy and hand, foot, and mouth disease, and I have no idea why I couldn't have those as well. So, yes, when he was 9, and we're talking 2011 now, this is when we received the formal diagnosis. This is when I started, going to the groups for kids on the spectrum, and was attending various talks that Autism Oxford organized at the time. This is when I first heard Paul Isaacs speak, and Olga Bogdarshina, and Tony Atwood. I still wasn't sure if I was autistic as well. Again, because, yes, I knew that I would meet the criteria on the screening test, but maybe I'm just playing into it. Maybe I just want to explain something that I don't want to change. Plus, I have to say my colleagues were not particularly helpful. They encouraged that sort of thinking that I'm just trying to resist changing, that I just need more therapy. I just need to really seriously commit to changing my behavior, etc., etc. So it wasn't until I blew whistle in my trust for the second time, and I started experiencing the repercussions that I was diagnosed myself, which was in 2016. It took me a couple of years of learning and thinking about it before I started contributing to the online discussions and sharing my knowledge.
You have over 16 years of clinical experience as a psychiatrist. So I'm just thinking about, based on this experience and your lived experience, what suggestions do you have for psychiatrists when working with autistic patients?
In March, I gave a presentation in New York at the Disability and Inclusion Conference, which was organized by my friend Sam Leben and the Torah Law Institute Toro Law Center. So I gave a presentation there on my personal experience as a patient in a medical hospital, and how I was nearly detained under deprivation of liberty safeguards and Mental Capacity Act, which was a very traumatic experience. From that, you can find that presentation online. It's on my LinkedIn. From that experience, I guess I would say I have 3 pieces of advice. And the first of it is curiosity. You have to be curious. You have to ask why. Why does the person behave this way? Every behavior has reasons. Every behavior is communication. We say it so often that we don't even think what it actually means. But essentially, even psychosis, even psychotic symptoms, delusions, they originate in a personal history of a patient. Any behavior can be understood and reasoned through based on an understanding of the patient. No matter how unwise you may think it is, no matter how maybe irrational it is, even, quote unquote, insane the behavior appears, it has reasons that can be understood. And once they're understood, those reasons can be addressed, and the rapport with the patient can be established where the actual communication begins. So I think that's the most important one. The second one is, we all learn about autism in medical school and in our postgraduate training as psychiatrists. Knowing about it enough. You need to understand how your autistic patient lives. Always emphasize that we don't live in the same reality as neurotypical people. We perceive physical space differently, and we perceive the time differently. And since space plus time equals physical reality, we perceive the reality in a very different way. So you need to understand how your patient perceives the reality and how they process it. And I guess the best comparison would be, the much talked about concept of multiculturalism. We keep talking about multiculturalism and how we need to understand how our ethnic patients see the world, how they are used to thinking about particular social situations or particular social interactions, and how they experience particular transitions in life. But autistic people, essentially a culture on their own, in the same way that, Russian people and Sikh people and Pakistanis are the culture on their own. So we need to really educate medical students on neurodivergent multiculturalism, that I think. And it needs to be done by autistic psychiatrists, because, there has been research that showed that if you do the autism training or neurodiversity training and deliver a lot of facts, but the person delivering the training is neurotypical, the people afterwards know lots of facts, and they may be very helpful facts, but their attitudes towards autistic people and autism, the stigma is not shifted. The attitudes don't change. But the mere interaction, mere exposure to the autistic person, it's a bit silly. I'm talking about it like, exposure to a curio in a museum. But an exposure to autistic person, if the same lesson is being delivered by an autistic tutor, knowledge is benefiting, the levels of knowledge among the audience are increasing, but the attitudes change independent of that. So they observe the improvement in attitudes, change in attitudes towards less stigmatizing one, even if the levels of knowledge do not shift. And I think this needs to be talked about more, and any training, any kind of attempt to change the attitudes among medical professionals need to be based on that principle. And finally, I think this is a very small but significant point. You need to be ready to learn from your patients. Carl Jung wrote that the most important conversations of his life were anonymous. The most of what he learned was learning from the patients. And, if Carl Jung was able to write that, and if he was able to recognize that, I think, an average psychiatrist must be able to do that.
Absolutely. Now, currently, you're the director and founder of Autism Doctor, in which you use evidence-based medicine and positive psychology to help clients overcome their barriers, leverage their strengths, and unlock their potential. So I'm wondering, are there specific principles of positive psychology you found that are particularly helpful to us as autistic people, particularly those that you've worked with?
Positive psychology, I think the concept has been taken a bit too far, to be honest. And I'm kind of shifted away from this. And the reason I am a bit concerned about emphasizing it too much is because we have been talking about positive psychology as a panacea for all kind of psychological malaise. I think it puts this sort of unrealistic expectation into people's heads that you have to be positive all the time. You have to be happy all the time. And that's just unrealistic and impossible. You're allowed to feel bad about yourself. You're allowed to feel low from time to time. It only becomes a problem if it's a persistent, pervasive feeling, which is when you need to seek help. I think examining my own life, thinking back, I think as a child, I had pretty dim childhood. I spent most of it in the hospitals. What I didn't spend in the hospitals, I spent at home, because the moment I would go to school, I would catch some bug and then would be again at home on the sick bed. I had to adapt to, as my husband says, just dealing with it. I arrived before I learned about Stoics and Stoicism. I kind of arrived at this thought that, okay, so I can't change this. What is the best I can do with what I've been given? This kind of approach has helped me through a lot of really difficult times in my life. And now that I've learned that great minds such as Stoics have been advocating this for thousands of years, I strongly support that theory. However, I think there is much to be said about positive self-regard and positive view of yourself. And this is where I tend to start with my clients, with people that come to me seeking help. Focus on your strengths. Focus on the way you can use your strengths and leverage them in order to compensate for the weaknesses. From the time when I realized that my son was autistic, I brought him up with a view that I kept repeating, sometimes on a daily basis, that you are just a kid with a brain that is slightly different, that works differently than brains of other people. And every person has their own weaknesses. Every person has their own strengths. What you need to do is to learn to use your strengths to compensate for your weaknesses. And you have a brilliant brain. You can do that. There are some things that you're very bad at, and that's fine. Nobody is good at everything. But there are some things that you're good at. And as long as you find those things and focus on them and use them to achieve self-fulfillment, you will be fine in this life. From there, with my clients, because I work with adults, we have to go back. We have to look at the past and reframe the events that happened to them, the traumas that occurred, the kind of struggles they went through, and the challenges they overcame. We focus on the positive reframing of those events in a way that the person no longer sees themselves as a victim of circumstances with no agency, because this is how many of my clients have come to view themselves over a period of time. Several decades of constant humiliation and trauma will do this to you. They have been told again and again that they are broken, that there is something wrong with them, that they are not doing well enough, that they are not working hard enough, that they are not trying hard enough. And we have to peel that back layer by layer and say, no, you have been doing fine. What was wrong is how you have been treated by others and how the circumstances were not adapted to your particular strengths and weaknesses. And once the person internalizes that narrative, the change in the future and the sense of agency in the present develops, and the change in the future becomes much, much easier. The only thing I would add here is that, there are some people who get stuck on some particular regret. A lot of people get stuck on their anger and the disappointment with their parents. And they have a lot of reason to be angry and disappointed. Their parents didn't understand them. The parents expected something that the children, my clients who were children at the time, were not capable of delivering, and they shouldn't have been expected to deliver. And this kind of anger and frustration and resentment, it poisons the present of the person. It poisons their ability, destroys their ability to affect effective change. In those cases, I would suggest asking yourself, what are you trying to avoid, or what are you avoiding by focusing on the resentment and not being able to let it go? Because at the end of the day, the past is the past. You can't change it. You can look at it differently, but you can't change the actual events that happened to you. But if you are able to accept it, then you're able to stop wasting energy on the regrets and move on in a much more positive frame of mind, capable of being the best of yourself.
I wanted to ask you about evidence-based medicine, because medication can be so important to us as autistic people, but often prescribed medication doesn't work or has negative side effects. So what does evidence-based medicine say about kind of best practices for psychiatrists prescribing medication that actually improves health outcomes for autistic people?
The problem is there is very little research about effective use of psychiatric medications in autism. There was a recent systematic review / meta-analysis done on the use of antipsychotics, and that was done on use of antipsychotics in autistic people for purposes of controlling aggression, which really I think is very limiting, and I have a lot of difficulties with phrasing of that question, because as I said, any behavior is communication, and if you understand what the person's aggression is actually communicating, you don't need antipsychotics for that. Even that systematic review came to the conclusion that optimizing the person's environment and modifying the modifiable factors And vigorous aerobic exercise, that's literally what it said. Vigorous aerobic exercise should be the first line management options for aggression in autism. Now, as far as antidepressants are concerned, there was another systematic review, I think in 2017 or 2019, that said that fluoxetine and sertraline have the most evidence behind them. And apparently sertraline is preferred because it has a better side effects profile. Personally, I am not confident about that particular recommendation because, and that is, please don't take it as medical advice. This is just me saying this based on my personal observations and experience. Fluoxetine, it's a bit like aspirin, it's a dirty drug. It has it acts on many different levels that are more fine-tuned medications as sertraline avoid. So, and fluoxetine is the oldest of SSRIs. And really, the pharmacokinetics and pharmacodynamics of fluoxetine, which means how our body processes it and how it's metabolized, I think it's much milder and much better, much more tolerant in terms of maybe forgetting a dose or missing a dose, or you don't experience the same levels of dose fluctuations in the system as you do with sertraline, because fluoxetine's half-life, and this means the amount of time that it takes your body to eliminate 50% or half of the amount of fluoxetine in your blood. So fluoxetine's half-life is 72 hours, which means your level of fluoxetine in the blood, provided you take the medication every day, is going to remain stable once it's reached the optimal level. Whereas with sertraline, you're going to experience constant ups and downs as the half-life of it is much, much shorter. And I've noticed that autistic people are sensitive to this diurnal variations of the levels in sertraline. So in my experience, fluoxetine is much better tolerated. But again, this is not medical advice, and please consult your own physician.
Yes, please consult your personal physician, certainly.
Exactly. But having said all that, I am not a big fan of medicine as a first, despite being a psychiatrist, I'm probably as far from the drug pusher as you can get, because I firmly believe that there is much optimization that can be done in terms of the person's sleep, in terms of their food intake, in terms of their overall health, in terms of their physical activity levels. You really should only turn to medication when everything else has been done and optimized, and it's still you still don't manage, or if the symptoms are so severe that you can't really do anything without modifying either anxiety or depression first. So, my approach to depression has always been physical activity, and it doesn't have to be particular sport. It can be walk for a certain period of time. It can be painting your house. It can be doing something in the garden. You just need to be physically active. Mindfulness or meditation, whatever way you want to look at it, just some space for yourself to sit with yourself and to find this sort of place of quiet, place of being centered on yourself in your mind, and optimizing the environment. And once that has been done, then I would consider medication. But because autistic people are so sensitive to both effects and side effects of medications, my approach to medication has always been start low, go slow. So the starting dose should be possibly even half of the recommended starting dose, and then increasing it in very small increments over a period of time, and just to the level of response, which can be lower than it would be recommended for a neurotypical person.
I've been grieving for over 6 months now, so I was very interested to find in preparing for this interview a presentation you gave regarding the intersectionality of grief. So why was it so important for you to create this presentation?
There were several factors, really. One factor is that it's the question that I have received very often, both on my Quora space. I have a space on Quora. It's autisticpsychiatrist.quora.com, and just receiving personal messages from people, because people have finally begun to realize that autistic people may be reacting to grief in a way that is substantially different to the way a neurotypical person reacts. And there has been a lot of interest in the last sort of 18, 24 months about this topic. Second, I felt that I was well placed to create a presentation because I have several personal experiences of grief. And actually, my first experience of grief, I lost my pet when I was 8, and that was extremely traumatic for me. I lost it in a very traumatic circumstances, and the whole thing was awful. And then I experienced several losses as an adult, and I wanted to share what I have learned from my personal experience, kind of joined up with what I have learned by doing research on the topic, in order for people, maybe to get some helpful suggestion. If it helps somebody who is either going through the experience or who is close to the autistic person that's grieving, I would be. I think the presentation has done its best.
Now, one of the learning objectives in the presentation was regarding frequently used psychological defense mechanism an autistic person may employ during the grieving process. So what are some of the most frequent ones to look out for us as autistic people from people's loved ones, or for ourselves for that matter?
Obviously, it varies from person to person, just because we're all different. But there are several themes that of the defenses that we most often employ, and also the ways that we tend to be perceived, or the ways we react to grief that can be misunderstood. And I think one of the most common ways is perseveration. We persevere a lot. We focus on the object that we grieve, and I use object as a it could be inanimate, it could be animate object. It's just the object of the grief, what we have lost, and it can take form of perseverance of thought. Sometimes we can't stop thinking about it. We keep replaying scenarios about either the process of loss or the memories that we had, or our current emotional reaction can just come on in waves and overpower us. So that's links into the emotional perseveration. And I've observed it so many times where the person can appear to function and not appear impaired by their grief, and then suddenly they just collapse in tears, and they're inconsolable and they can't speak about it. The emotion is so strong and so overpowering, it's impossible to resist, and it can be quite scary experience for people who observe it. And it can be the action. We can keep going to the place or where the loss occurred. We can keep repeating the actions that led to the loss. We can invent rituals that soothe the feeling of loss, or sometimes, and this is bordering on psychotic, believe that it would prevent the loss or somehow would bring the object of grief back to us. We can keep rewatching the same movie. For example, if I know somebody who lost their husband and they just kept their wedding movie on the loop for months on end. That's all they did, coming home from work. They were not able to do anything. That was their way of coping. So perseveration is a big one. And linking to perseveration is intellectualization. And what I mean by intellectualization is we're trying to learn everything we can about the topic, about the object of grief. I remember when I was diagnosed with diabetes, I was grieving my health. And all I could do for weeks was to research diabetes on the web and what is available and what can be done and what is going to be happening, what the research is. So we use our strengths, and my particular strength is the cognitive strengths, to cope with the emotion and keep the emotion at bay. So these are kind of the main defenses that we use. Emotional detachment is very frequently used, the third one, where we don't allow ourselves to process the emotion. We just know that the loss occurred on the intellectual level, but we can't allow ourselves to experience it because, again, the emotion can be extremely overpowering. And then in terms of how we're perceived, what the grief reactions of autistic people that are most often misunderstood, the delayed processing, where it takes us time to actually fully process and fully experience the loss of the object of grief, which can be interpreted as unfeeling reaction or indifference or just being shut down emotionally or not caring, and that can create a lot of complications in our personal lives. Regression, where we need more care and more looking after than we otherwise would. So it's almost like we become younger, we become like children who need to be looked after. And that occurs especially when we lose our parents or lose somebody who was looking after us. If a wife depends on a husband a lot, then it's likely she may experience regression in the grieving process. And quite uncommonly, there is aggression and withdrawal. Now, withdrawal is the sort of extreme grief where we just stop engaging with the outside world. And it can go to the point of catatonia, which is when you are awake and you hear and understand things that are going around you, but you can't even move a muscle, much less respond in any meaningful way. So yeah, this is, I would say, the most common reactions to grief.
Thank you very much for that. I definitely relate to the perseveration and the intellectualization of things. I doing a lot of research about grief in these last 6 months, so I appreciate that. And lastly, Doctor, how can our listeners learn about you beyond this interview?
I have extensive presence on LinkedIn, so I can go on linkedin.com/in/autistic psychiatrist. I have presence on Quora. As I said, I have my own space there, which is autisticpsychiatrist.quora.com. And I'm just launching my website. It's a bit bare bones now, but there is a lot of content coming in the next couple of weeks, which is autismdoctor, all one word, .org.
Well, I will definitely be following you on social media and the updates to your website. So thanks so much, Dr. Wheatcraft, for joining me here today.
Thank you, Doug. I really appreciate the opportunity.
Thanks so much to Dr. Wheatcraft for the conversation. To learn more about Dr. Wheatcraft, please check out the link in the podcast description for this episode. We always love hearing from you and would especially love to hear from you relating to this episode on what are some of your personal strengths you feel proud of and can rely on. Here at Autism Personal Coach, our clients are the experts, our coaches are the guides. The majority of supports for our autistics are not helpful. They try to fix us, not support us. That's why many are confused when we say our clients are the experts of their lived experience. Our clients are the experts for what has worked for them and about the things they need and want in their lives. Our coaches first listen to our clients, then ask thoughtful questions, offer resources, and strategize with our clients so they can get what they need to thrive. Would you want a guide in your life to coach you, to help you to get the things you desire? If so, then visit autismpersonalcoach.com for more information. I hope you enjoyed this episode of Autism Stories. And if you did, if you could tell a friend, foe, or anyone else you know about it so they could have the same enjoyable and educational experience as you when listening to Autism Stories, it would be very much appreciated. Until next time, I'm Doug Bletcher of Autism Personal Coach. Talk to you then.